Hi, everyone. My name is Josh Bauml. I am a medical oncologist at the University of Pennsylvania. And I am so pleased to welcome you to the Cancer Grace ASCO ESMO update. So this is great. And I have some fantastic friends and colleagues here to talk about all the updates from head and neck cancer at these big conferences. So joining me today are Dr. Kathryn Gold, from the University of California, San Diego, Dr. Ranee Mehra from the University of Maryland, and Dr. Jared Weiss from the University of North Carolina. So we have a lot to talk about today, and that's wonderful. Let's start off by talking about the JAVELIN100 study. Dr. Gold, why don't you tell us a little bit about this study?
Sure. So this was a really exciting study. We know immunotherapy can improve outcomes for a lot of patients with head and neck cancer, but what we didn't know is whether it would help people who are receiving radiation for localized disease. So in this trial, patients were randomized between radiation in combination with chemotherapy or radiation with chemotherapy and an immunotherapy drug called Avelumab. We were all hoping this would be able to improve outcomes, but unfortunately the trial results were negative. They showed really equivalent outcomes with the immunotherapy or without, and with the concern for more side effects when the immunotherapy was added to the combo.
Yeah, this was really disappointing. And you know, one of the things that I thought was most interesting about this study was that they added the Avelumab, that's the PD-L1 inhibitor here, not only with the radiation and the chemotherapy, they added it before the radiation and the chemotherapy and after it for a year. So this is really a lot of immunotherapy they added, and the outcomes were very disappointing. Dr. Mehra, did you have any thoughts about why this might have been?
Well, you know, I agree. I think we were all somewhat surprised and disappointed about the results. I think one thing to keep in mind is that one of the endpoint was progression-free survival. I think that's been a challenging endpoint for most immunotherapy studies, and especially when, you know, we know that radiographic response may not really give us a true sense of what, you know, we're appreciating and what's happening, using that where we have to rely on the imaging to give a sense of if the treatment is efficacious or not, just may not be the best way for us to study these drugs. And overall survival in general tends to be, I think, a better endpoint, but that requires more patience and takes more time. So it's, you know, part of it is, you know, could have been related to the design of the trial.
Mm-hmm. So are you?
Yeah, so I found.
Yeah.
Go ahead, Josh.
No,
so you know, I found some things interesting here in thinking about the results. Yes, the arms were equivalent, but you know, there was a trend, right? We all worship at a statistical altar, but you would ideally like to see. I would have liked to have seen a trend at least in the right direction to say, right, maybe if we tortured the design a little bit, you know, academics torture data until it confesses something, right? So can we find a subgroup if you did this a little different? And I think it's important to note here that the trends for both progression-free survival, which I'll note is a curve that ticks down every time either cancer grows or a patient dies, or overall survival, which is exactly what it sounds like, that both of these trended in the wrong direction. These trended towards a hint of, I wouldn't say there was harm with Avelumab, but I would say that if there's any hint, it's in the wrong direction. And I would also note that when they tortured this data looking for a subgroup that might look better with the addition of Avelumab, they really didn't find it. Most of their subgroups looked worse in the experimental arm. And I think there was one by PD-L1 that maybe hinted a little in the right direction, but it didn't reach significance. So this was really across the board a cleanly negative trial. I wonder if timing was some of the problem here. You know, Josh, you brought up the design of immunotherapy before, during, and after. I suspect that the giving a checkpoint inhibitor a week before radiation is probably not the best idea. And I think we have timing questions that need to be answered. I know you're deeply involved in a study giving immunotherapy purely adjuvant, right?
Yeah, so we're looking at immunotherapy after definitive treatment, so after curative treatment for an aggressive head and neck cancer, patients are randomized to either pembrolizumab, which is a PD-1 inhibitor, or a placebo for a year. And this is very similar to what we do in lung cancer for high-risk treatment after radiation. And we'll see what the results of that are. I guess that there's two ways to think about giving immunotherapy along with radiation from my perspective. And you can sort of, as you said, torture data. We can also torture hypotheses, right? So on the one side, if I give the immunotherapy with the radiation, that is going to make all the cancer cells all excited that the immunotherapy is going to come in and the immune system is going to get activated, and there are all these neoantigens, which is a word that immunologists love to say, and like it gets the immune system all excited. And if that were true, then I would have expected that this trial would not only have been positive, we wouldn't have been talking about trends. We'd be talking about driving a truck through these curves. But the other side of it, and this is getting to what you were saying, Dr. Weiss, is that in the setting of giving immunotherapy before radiation, there's a worry that the immune cells, those happy, excited immune cells that'll kill cancer, rush into the tumor, and then we radiate them and kill them. And that is somewhat problematic. But what is really happening biologically, I would argue we still don't know. It could be either, both, or it could be neither of those stories.
Yeah, and in our study of pembrolizumab and radiotherapy, we saw quite a bit of lymphopenia, so that there is some support for that concern. So I guess in conclusion, we're not going to add Avelumab to chemoradiotherapy. This is a frank disappointment, just to be straight up about that. There are studies of other drugs being added to chemoradiotherapy that we will see. But certainly this gives reason to be concerned about whether we're going to have quite the advance there that we had hoped to. Any other thoughts on this study?
I guess the only other thing I would add is we really do need to think how to incorporate our biomarkers in this space. I mean, I think as we think about metastatic trials, we really do use the biomarkers in that setting, even though they're imperfect. And so maybe future trials, which I think should occur, would be better informative if we incorporated our biomarkers in the design.
Well, and to your point, in this study, it was only 73 patients, but those with high PD-L1 did trend in the right direction for the addition of Avelumab. And I guess time will tell if PD-L1 is the optimal biomarker, let's say. I think, your smiles, Dr. Gold and Dr. Mehra, and your smirk, Dr. Bauml, suggest perhaps your skepticism about its optimal characteristics, but I very much agree, right? If we can select the right patients who are going to help, it would make a world of difference.
Well, even though PD-L1 isn't perfect, it's feasible to do, right? We have a lot of much more scientifically, interesting biomarkers, but what's needed with patient care becomes a little trickier when you're trying to do high throughput genomics and tumor mutation burden in real time.
I would call attention to the fact that Avelumab has been negative in nearly every trial it has been used in. It was recently had a very big positive trial in bladder cancer, but Avelumab is the only PD-L1 inhibitor that did not beat docetaxel in lung cancer. And so maybe it's the drug. I mean, maybe we're making a whole lot out of nothing. So I think it would be very interesting to look if there are any data looking at pembrolizumab or nivolumab with radiation in this space.
And on that note, I would recommend you stay tuned, and there will be a separate podcast on pembrolizumab and radiation.